So next we'll be bringing up Dr. Joseph Carroll, who will be discussing adaptive optics, measures of visual acuity in albinism. Thank you. Thank you.
Thank you very much. This will be something a little bit different than you've been hearing about, but no conflicts of interest that are relevant to this presentation. I want to acknowledge funding sources that have contributed to the work I'm presenting today.
Okay, sure.
So, as many of you know, albinism is a condition associated with aberrant melanin biosynthesis, and this results in decreased or absent pigmentation in the hair, skin, and/or eyes. Importantly, all forms involve ocular manifestations, such as iris transillumination, macular translucency, photosensitivity, increased refractive errors, nystagmus, and importantly, reduced acuity, although this is highly variable. And the foveal manifestations include absence of a FAZ, loss of the annular reflex, and foveal hypoplasia. And shown here are just capturing those foveal manifestations, where on the left you can see a normal foveal contour. On the right is a patient with oculocutaneous albinism, showing an absence of the majority of foveal specializations. Now, one of the sort of controversies within albinism is understanding the high degree of anatomical variation in the patients. And so to illustrate that, over on the right, I show you two OCT images that should look fairly similar to you in terms of the foveal specialization. One of these is from somebody with normal vision, 20/16 acuity, and so the other one is from someone with albinism, 20/80 acuity. And so the foveal anatomy, in this case, in our hands early on, didn't seem to be predictive of visual function. But nevertheless, given this wide range of anatomical variation in albinism, there was an interest to in developing prognostic indicators of visual acuity in these patients. And the group in Leicester in the United Kingdom developed a grading scheme shown here on the right, where they grade the severity of foveal hypoplasia from 1, with fairly mild hypoplasia, up to 4, which is the more traditional foveoplana, or complete absence of foveal specializations. And those are listed here in terms of the extrusion of interplexiform layers, presence or absence of a foveal pit, lengthening of the outer segments, and widening of the outer nuclear layer. But in all cases, it's important to note that they simply remark these as binary, present or absent. And so when you look at this, you see there's fairly good correlation between acuity and the hypoplasia grade. However, it's important to note there's overlap in these grading schemes. Patients with very, very mild hypoplasia can have worse acuity than patients with very severe hypoplasia, and so it's not a great predictive measure. And so we looked for more quantitative grading schemes. And to do this, we went to the foveal cone specialization. Shown on the right is these are histological studies from Anita Hendrickson and colleagues showing the foveal cones increasing in their packing density as a function of development. And on the right is a concomitant elongation or lengthening of the outer segments that happens as a function of development. And these are things that we can now measure with non-invasive retinal imaging. In fact, when you look at the foveal cone specialization in terms of outer segment length, and importantly, we normalize the foveal measure to a parafoveal measure to normalize for overall global differences in retinal thickness. What we see shown in the graph on the bottom right, the black bar is the mean and 2 standard deviations of normal individuals, and all the blue dots are individuals with albinism, and you can see they overlap quite strikingly with normal individuals. So it isn't such that there's just absent or present outer segment elongation. It's quite a remarkable range. And so we sought to incorporate this into a new grading scheme where we looked at the interretinal layer excavation, the outer segment elongation, as well as the outer nuclear layer thickening at the fovea. And so when we do this, we get slightly better predictive value. Shown on the right in panel A is the predicted visual acuity from the Leicester grading scheme compared to that's observed. And on the right is the quantitative grading scheme where we actually measure all the foveal specializations, and you can see that the predicted values, it improves to a 0.74 R value, and 94.6% of subjects had predicted values within 0.3 log MAR values. But it's still not good enough, and so what I'd like to spend the last few minutes on is discussing why might this be such an imperfect relationship. Why does anatomy and albinism not predict visual acuity with high degree of accuracy? And so you need to return to what limits visual acuity in the first place, and that is the spacing of the foveal cones. And so this is an image of a patient with albinism taken with adaptive optics. Each one of the circles there is an individual cone photoreceptor at the central fovea. And if this is the limitation on visual acuity is due to the fact that foveal cones normally are connected via a private line or one-to-one circuitry to the brain, such that every cone is acting like an independent pixel, if you will. And so I've shown a Snellen letter E transposed overlying the array of cone photoreceptors, and you can see that in order to resolve that as an E, you would have to have exactly one cone photoreceptor per bar in this diagram, okay? So in this sense, the spacing predicts acuity. Importantly, in albinism, we see that foveal cone density, as I already showed you with outer segment lengthening, is highly variable, but we still see fairly normal packing topography. Here in this image, you can see at the bottom right-hand corner is the foveal center, and as you move away towards the top left-hand corner of the image, the cones get larger and more coarsely spaced. This is normal cone packing that we would see. And so there's really two possibilities. One, we could retain the intact private line circuitry such that whatever cone density the patient with albinism happens to have, the acuity that we are able to measure in their eye would match the predictions from the cone spacing. Alternatively, they could have altered circuitry between their foveal cones and their downstream retinal circuits. In this case, acuity would be worse than that predicted from cone spacing. So what we did is we took images from patients with albinism and normal individuals, mapped their entire foveal ROI, counted all of the photoreceptors, and developed spacing maps shown on the right, where we can extract estimates of predicted acuity based on any one number of a factor, but we could take the minimum spacing, which would be the theoretical best acuity that this retina could achieve, assuming everything is intact with respect to private line circuitry. We then use our adaptive optics device not to image the retina, well, it also takes a picture, but to deliver a stimulus to the retina. In this case, it's a negative stimulus. This isn't a photoshopped E. This is actually the E that's landing on the retina, bypassing all the optical imperfections. And so then we can actually do psychophysical experiments to measure the adaptive optics corrected acuity, not clinical BCVA. We do this with standard psychophysics. We have 2 randomly interleaved staircases. We run approximately 30 trials per session across those 2 staircases, and then we can generate psychometric functions and estimate the acuity threshold for every single retina that we're studying, and then compare that to the predicted acuity measurements from the direct images of the photoreceptors. What I'm showing you here is our currently unpublished results, but the dotted black line there would be a perfect one-to-one relationship where the predicted measures from cone spacing match what we measure with the adaptive optics. The solid blue circles are from normal individuals. You can see they hover right around the one-to-one line. And then the few orange dots out to the side are our patients with albinism. They have visual acuity that is far below what is predicted by cone spacing, which would be consistent with disrupted retinal circuitry in these patients. Interestingly, the 2 open circles happen to be from individuals with hypoplasia due to premature birth, and they are interestingly somewhere between the 2, although that's still a subject of continued study. So what I've shown you is that despite having severe pigment deficits, patients with albinism can have foveal morphology and cone specialization that overlap with what's seen in normally pigmented individuals, and this would suggest at least partially independent developmental mechanisms underlying pit formation and cone specialization. Individuals with albinism have our AO corrected visual acuity values that are below that predicted by spacing of their foveal cones. And this would be consistent with altered post-receptoral midget pathways, as has been reported in a retina from a patient with hypoplasia and a history of premature birth. That was from Dennis Stacey and colleagues. That was shown in a histological section in recent years. And then future models obviously would need to incorporate measures of nystagmus into any modeling, because that can, of course, degrade visual acuity. And with that, I thank you for your attention, and I'd be happy to take a question.
Thank you, that was fascinating. Does anyone in the audience have any questions?
Joe, very nice talk. May I know whether there are studies looking at retrograde lighting of the photoreceptor from reflected light because these are albinism patients, there would be reflected light
So
coming from behind.
Perhaps whether they have reduced contrast sensitivity and things like that is what you're looking at? There aren't good measures of I'm not aware of any large-scale study of contrast sensitivity in albinism, but I might hypothesize that certainly due to the absence of melanin in the RPE, there would be increased scatter, so that certainly could affect vision in a meaningful way. That's something we should definitely think